All right. Hello and welcome to our final lesson. And what better way to end than here inside the stomach as we talk about drugs that will affect the digestive system. Oops, sorry. Now, keep in mind that some of the things we'll be talking about today are vomiting and diarrhea. And just like coughing, these are defensive mechanisms. Coughing, diarrhea, vomiting, these are ways your body has of protecting itself. So, in some cases of diarrhea or vomiting, we may not do anything, or we may not be too worried about it. Um, the but there are times, uh, just like with coughing, there are times where vomiting and diarrhea become so excessive that they're doing more harm than good. So, what will we be talking about today? Well, we'll be talking about drugs that um, will help in a variety of circumstances. Sometimes, for example, patients eat things they shouldn't eat, like this is this is rat poison, the telltale green sign. Most of these work by making the rat bleed to death by antagonizing the actions of vitamin K. And dogs will eat that because it's delicious. And so we have to sometimes make the dog vomit. Isn't that what great? Sometimes we have patients who are vomiting excessively. This is just some video clips of vomiting. Um, um, Almost every species vomits. You'll see there are a few species that don't vomit, and there are times where it's doing more harm than good, and we need to step in. Some patients develop diarrhea. That is not diarrhea. If anybody thinks that's diarrhea, let me show them. Right, this is diarrhea, and that's diarrhea. And again, a little diarrhea we may not be too worried about. It depends. But if it becomes excessive, just like vomiting, it can cause dehydration. It can cause changes in, you can lose electrolytes, and that can affect your acid base balance. It can affect your ability for cells to function. So we worry a lot about electrolytes and water when it comes to vomiting and diarrhea. Constipation is another problem we deal with. Sometimes the constipation is kind of a primary problem. Cats can get this disorder called megacolon, where the colon refers to the large intestine, the very last part of the intestinal tract, and just becomes this sort of gigantic, weak balloon that just cannot effectively move feces forward. So that's one kind of constipation. Sometimes the constipation is due to some other problem. Um, Dogs and cats and other animals that have some sort of a neurologic problem where they're paralyzed in the back end. They may still be able to poop, but they're just not getting the usual exercise that they might get, and so they're prone to developing constipation. Some patients can have a pelvic fracture, so that could put them at risk for developing constipation just because it hurts to go, and so they might hold it in, and they might hold their feces in because it hurts so much to defecate, and you'll see how that can lead to constipation. I just want to show you, this is a normal radiograph of an abdomen. This patient's in right lateral recumbency. And in here you can see the small intestines and then the large intestines. There's feces in that large intestine, right? This is normal. And this would be what you would see in a constipated patient, right? This is just full of feces. The colon is just jam packed with feces. So that's got to be uncomfortable. We also see problems that maybe aren't exactly constipation, but you'll see how the horse, you're looking here at a horse on the side of a horse. The horse has um, a really unique colon, a really unique large intestine, and it's prone to developing all sorts of problems, including an impaction, which I guess is kind of like a constipation. It's just certain parts of the intestinal tract can get impacted. So here you're looking at part of the colon, and it's getting impacted with feed, sand, and so we can use constipation medications to help this horse. Um, this is a whole other problem we see. What are we looking at here? This is actually a horse's stomach, and I'll explain later what the difference is between this part of the stomach and that part of the stomach. But you see it's happy, it's pink. What's all this over here? All these kind of cracks and craters and well, those are what are called ulcers. So horses, dogs, cats, you and me, cows, we can all develop what are called gastric ulcers. And we'll learn more about why the horse in particular is, um, is at a high risk for ulcers. We see problems with bloat, where the stomach, or in the cow's case, the rumen fills up with air, gases. And then what can we do about it? Well, these are the drugs that we can use in these situations. We have emetics to make them throw up, antiemetics to make them stop throwing up, antidiarrheals, laxative, cathartics, purgatives, antacids, drugs that can help the rumen, especially for bloat, antibiotics, electrolytes, pancreatic enzymes, corticosteroids. And there's a few things I'll mention that I think you'll find helpful that are not in the book. And there's a few things in the book that are not helpful. So anyway, welcome to chapter 4. Our goals are going to be to describe the functions of the gastrointestinal tract. We'll describe the autonomic nervous system's control of it, describing how vomiting is stimulated, what receptors are used by drugs to either induce or control emesis. We'll describe how diarrhea occurs, by what mechanisms drugs can be used to control diarrhea, describe how laxative, cathartics, and purgatives produce their effect. We're really not going to talk about purgatives. The book doesn't even really mention purgatives. I'll tell you what it means, but describing how stomach acid production is controlled and how antacids and anti-ulcer drugs can work, describing drugs that can be used to maintain rumen health. Again, our real focus is going to be bloat. Describe the role of antimicrobials. We'll also be describing the role of a little bit about glucocorticoids, and like I said, there's a few other things that, like probiotics, a few other things that we'll mention. The chapter has at least 4 or 5 drugs that it says are not effective, so I don't even know why it includes them. So we're not going to talk about them. Well, let's start by talking about your actual gastrointestinal tract. There are a lot of species differences, and we'll talk about that today. Dogs and cats are carnivores, pigs are omnivores, horses, cows, rabbits are herbivores. They're all a little different. I think dogs are actually technically omnivores, but a lot of sources say that they are carnivores. So, all right. So let's, as we talk about the functions of the gastrointestinal tract, it's helpful to remember that it's just this tube. Think of a worm, all right, a very simple worm. Its gastrointestinal tract is just a tube that runs through it. And an example that's often given is a donut. You are a donut. There's this hole that runs through you. The hole is not really part part of the donut. It's this space that runs through the donut. Well, you have the same space. It has a lot of twists and turns, but it's still technically outside you. Now, that's good in some ways. It's also bad in some ways because it means that some disorders of the gastrointestinal tract are hard to diagnose. You can't really x-ray them. You can't do a blood test for a lot of them. Gastric ulcers, for example, we can sometimes get some clues that a patient has a gastric ulcer, but there's no blood test for a gastric ulcer. So we're gonna take two different tours through the gastrointestinal tract just to familiarize ourselves with the various parts, starting with something you ate and pooping it out. And you can think of the gastrointestinal tract as like a subway station, right? Starting at the well, really starts at the mouth, but going from the esophagus, the next stop is the stomach, the small intestine, going to the large intestine, and then there's sort of some side routes, right? The liver produces bile, you'll learn about that. The pancreas produces various digestive enzymes. The appendix in you and I doesn't do much, but the appendix is very important in rabbits and horses. It's called the cecum, and it's huge in those species. And then, of course, that's a strangely long rectum. But anyway, just think of it, this tube, as a series of stops. And what does the digestive system do? Well, if we count everything from the mouth and the lips to the anus, it all starts by what's called ingestion, right? The actual taking in of nutrients. Think of the long tongue of a giraffe or an anteater, or the lips and mouth of a cow or you, right? Actually taking in the nutrients. Then it gets broken down into smaller components. That's called digestion. Then those smaller components actually get absorbed across the intestinal wall, primarily the small and the large intestine. That's what you're seeing here. That's your breakfast going by. And then what's sometimes called egestion or excretion is the actual removal of these waste products. And various problems can develop along the way. So again, we'll start with the mouth. Of course, this is where ingestion takes place. You've got the mechanical action of your teeth and your tongue mixing and grinding. And then you have saliva that's produced that helps to moisten the food. Some species have enzymes like amylase in the saliva that begins the digestive, the process of digestion, actually breaking some molecules or components into even smaller components. The esophagus, right, there's this tube. It's made up of smooth muscle, and it's going to connect the pharynx to the stomach. It's got a sphincter muscle. Sphincter muscles are muscles that can close tight, and it's got one on top, the upper sphincter, and then one right where the esophagus meets the stomach. That one's called the cardiac sphincter. And the idea, of course, is that this is a one-way street, right? Food is propelled down the esophagus by these waves called peristalsis, waves down the esophagus. But of course, cows have the ability to regurgitate, and we'll talk a little bit about that. The stomach is this J-shaped sac of acid. It's worth remembering that the pH of stomach acid is about 2, and as your book says, that's enough to burn through cloth. And you carry it around with you all the time. It can stretch to hold more food. It has, of course, there's that sphincter muscle I told you about, the esophagus, where the esophagus meets the meets the stomach. Here they're calling it the esophageal sphincter. There's another sphincter down here called the pyloric sphincter, and that helps control the exiting of food. And the stomach also churns, it helps to mix food, and there's a lot of chemical digestion that occurs here with acid and with a particular enzyme called pepsin. And pepsin helps to break up proteins. We mentioned there's various salivary glands. There's also other what we call accessory glands, right? They're not part of the tube, but they introduce substances into the tube. The pancreas introduces various digestive enzymes. The liver produces bile, which is stored in the gallbladder in some species, and that gets introduced into the intestines. The pancreas sits sort of right behind the stomach. The first part of the small intestine is called the duodenum, and you can just imagine in your own duodenum, there's this loop of duodenum, and the pancreas sits right there. We've talked before about how it's sort of two organs in one. It has an endocrine portion that's making insulin and glucagon, but today we're talking about this other part of it that has an actual duct that enters into your small intestine and releases various digestive enzymes. Again, enzymes can do a lot of different things. These enzymes are breaking up food particles. There's amylase that will break up carbohydrates. Lipase breaks up fats. Trypsin breaks up proteins. And the pancreas also stores and releases bicarbonate. And bicarbonate is to neutralize acid. All that stomach acid coming through the pylorus, that could burn your esophagus. And so the pancreas will help to neutralize that. It also produces various hormones that we're not going to say much about, but they communicate to the stomach to maybe slow down so that the small intestine doesn't get overwhelmed. It's interesting, but we don't have time for it. The liver, of course, produces bile. It does a lot of things, but we're just talking about one thing today. It produces bile, and bile's job is it's going to help break fat up into smaller globules of fat, and that will help the pancreas and its enzymes to digest it. It's not, so it won't be this big ball of fat. It'll be these little emulsified fat globules. And then the liver also, when nutrients get absorbed from the small intestine, they enter the hepatic portal vein, which of course goes to the liver, and the liver can extract nutrients from that and toxins as well. And of course, the gallbladder, horses do not have a gallbladder, mainly because they are just continuously eating. But for you and me and dogs and cats, species that just eat certain meals during the day, when we eat, then the gallbladder will contract and squirt a bunch of bile in. Horses make bile. They need bile. They just don't store it. They just continuously drip, drip, drip bile into their duodenum. And then we mentioned the duodenum. So this is part of this very large part of your digestive system. There's three parts: the duodenum, the jejunum, and the ileum. The duodenum, there's a lot of mechanical and chemical digestion that occurs there. We mentioned lipase, trypsin, and amylase from the pancreas. And most nutrients will get absorbed here. Not all, but most will. And then, of course, there's a lot of mixing and propelling food forward that we'll talk more about. Once that food reaches the jejunum and the ileum, they have their own enzymes that are going to help to further break down amino acids and disaccharides, right? So amino acids come from proteins, and disaccharides will come from carbohydrates. So they're going to just break things down a little more. And that's what you're seeing here. Right, that's just food being moved forward through the small intestine, and at the same time, nutrients are being absorbed. And then the last part is the large intestine. That's part of the colon. So the large intestine technically includes the colon, the rectum, the anus, the cecum in certain species. The main function of the colon is what you're seeing here is to absorb water. That's a very important part of what the colon does. There you see there's water being absorbed through the wall of the colon. And there's also a whole bunch of bacteria that live here. These are good bacteria. And among other things, they actually produce B vitamins. Some of your essential vitamins you make yourself with your bacteria. And then the final stop that we're not going to say much more about is the rectum and the anus. Again, the rectum sort of stores food. There's sphincter muscles at the anus that relax and allow the excretion of food. And what I wanted to do is actually take a moment, and this is a little video of a human digestive system. So let's actually see all of these parts here. Right, so we're just
digestion starts in the mouth. Teeth grind up the food. Then, special glands under the tongue pump out saliva to help break down and lubricate the food on its 12-hour, 13-foot journey through the gut. It'll pass from the stomach into the coils of the small intestine before finally passing into the large intestine. Waves of contracting muscle keep the food moving, a process called peristalsis. These contractions are so powerful, we can even eat upside down. For the first time, a new camera shows a high-definition view of how food travels through our bodies and into our stomachs. Food enters the stomach through a hole at the top.
So there's that sphincter muscle. You saw how muscular that looked.
The stomach is a bag of muscle that churns, squashes, and squeezes food into liquid.
So that's the stomach acid.
At the same time, acids break the food down. The stomach walls protect themselves with a lining of mucus. Without it, the acids could digest parts of the stomach itself, causing stomach ulcers. About an hour later, the stomach squeezes the broken down food out through a tiny hole called the pyloric sphincter.
We got another muscle.
The food enters the small intestine, an 11-foot coil of tube where we absorb most of the nutrients. The interior wall of the small intestine is lined with millions of microscopic projections called villi. These increase the surface area of the gut, making it easier to absorb nutrients. pancreas pumps out a juice that neutralizes stomach acid.
That's the bicarbonate.
Then bile from the liver breaks down the fats into tiny droplets.
So,
smaller droplets are easier for the intestine to absorb.
right, all that green stuff.
After an hour and a half, the small intestine has absorbed most of the nutrients from the food. It's time for what remains to move on. It enters the large intestine through this, the ileocecal sphincter, a valve that keeps our food from going back where it came from. What's left is a mix of waste food and dead cells from the walls of the gut. The large intestine's main job is to extract water from it. Lots of bacteria live here too, but it isn't because of an infection. We actually need them. They produce enzymes that break down complex carbohydrates in our food, carbohydrates we couldn't otherwise digest. Finally, after about 12 hours, we expel what's left of our first meal.
All right. Yes, I forgot to mention that last part, that in addition to absorbing water and making B vitamins, there's even a little bit more digestion and absorption that occurs in the colon. So, as I said, there's a lot of things that different species have in common, but there are some big differences between each species, right? So the pig and the cat they're mostly similar to you and I, right? There's the esophagus, the stomach, intestines. Pigs have, well, they have this thing called a spiral colon. That's not important. And as you go on in your careers, you'll hear more and more about some differences. You know, how the cat's intestinal tract is much shorter than a pig's, for example. Horses start out looking like any other animal, but then they have this really gigantic, the large intestine. Their colon, their cecum is just huge. And then cows, their stomach is right here, the abomasum, but they have these 4 chambers that we'll talk about. And so they're very different. Cows and all of the ruminants, moose, buffalo, goats, sheep, elk, deer, reindeer, you name it. They are all, they have these slightly different structures here. So in fact, we'll start just by talking about some of the differences with the cow. The cow does have a true stomach. That's the abomasum. That's just like yours and mine. It's got the acid. It's making mucus. Cows have this first chamber called the rumen, and it's this giant fermenting vat. So food goes in there, and this little video kind of shows you that here. You could think of this as a more elaborate stomach if you want. You and I are what are called monogastrics. The cow, they don't call her a quadrogastric, but that's kind of what she is. The abomasum, like we said, is the true stomach, but the rumen acts as this giant vat. There's bacteria and protozoa that are causing this process called fermentation to take place. It's taking place in this kind of low oxygen environment, and it's actually the bacteria and the protozoa that are breaking down the grass and grains that the cow is eating. we see the food coming in here. This was the video from the from this week's page. Let me just kind of fast forward here, right? She takes her food, right? The food travels into the there's the reticulum, and what you're seeing here is the rumen is on the left side, so you're kind of seeing through her. But just imagine that's on her left side, and that's food traveling around. There are bacteria traveling around and eating, helping her to digest, and then she's able to regurgitate it, chew it some more, help break it up, and then it just goes back and back again um, to the rumen. And it's in the rumen, all these bacteria and protozoa will eventually die, and they will travel to the abomasum and be digested as protein. And we don't need to go into great detail about everything that's happening with her, but just appreciate we're going to travel through her esophagus, and you'll see part of her digestive system. But just to appreciate, the rumen is very different from anything that dogs and cats and horses have. It's just this giant chamber. So this is not acidic. This is not an acidic chamber. This is not like stomach acid. This is actually probably a more neutral or even alkaline environment. But it's moving, it's churning, it's mixing everything up. Again, that hole leads back to the esophagus. Here's all these microorganisms in the rumen that are helping to digest the food. Eventually, the food passes into the reticulum. That's the second chamber. Again, there's more food coming in through the esophagus. And eventually, some nutrients are going to leave, as well as all the dead bacteria and protozoal traveling through the omasum. And then finally, we reach the true stomach, which is the abomasum. And this looks like the other stomachs, right? You got these sort of these folds, and there's stomach acid here. So just to appreciate, it's very different. The horse is yet a totally different system. Food goes into the rumen. A lot of nutrients get digested and absorbed in the small intestine, but then the horse also uses fermentation to make a special kind of fuel, just like the cow does, and that all takes place in the large intestine. They have this really huge large intestine. It goes, it travels caudally, and then it loops back on itself and goes to the other side of the horse, where again it loops. So it's kind of shaped like a giant horseshoe that's folded over. And on the right side of the horse is the cecum, which is like the appendix. You and me, we've got this tiny little appendix. The horse has this just enormous cecum. And again, it's bacteria living there that are causing the breakdown of all these carbohydrates. And it's important to know that horses and rabbits cannot vomit. It has partly to do with the angle of the esophagus. They have a really strong sphincter muscle there. It's just impossible for them to vomit. Same with rabbits and a few other small mammals. That creates some problems for horses and rabbits, where gas can build up, and it's painful. And it'd be nice if they could just burp, but they can't, or they can probably burp, but they can't vomit. And there are some problems where they could vomit, it might help them. And as I said, the colon and cecum perform this fermentative digestion that's making this special fuel source, helping to break down the various grasses and other plant material that the horse is making. And just like the rumen and the cow has to be kept in balance, the same is true for the colon and the cecum. It's quite complex, and problems can develop there. This little video takes us into a horse's colon. So we're just going to, so here we are looking at the side of a horse. And again, there's the small intestines. And in most species, the large intestines would be fairly small. But the horse, you can see it's huge, right? This is a really huge, large intestine. You see how it doubles over here. So these spots where it doubles over, when I say doubles over, I mean it makes like a U-turn or a hairpin turn. That's a common site for an impaction or an obstruction to occur. And then over here, you can see part of that cecum, that gigantic blind pouch in the horse. And so we're just going to kind of zoom in here. There's the cecum, right? You see how it's just kind of this dead end. So food goes in and then it can get digested. Here we're seeing some of these carbohydrates. They're going to get broken up by bacteria. So you'll see the bacteria come out. So these would be disaccharides or polysaccharides, and little protozoa and bacteria will break them up. And then there's that fuel source I mentioned. They're called volatile fatty acids. You don't need to know that, but not for this class, you don't need to know that. You need to know that if you're taking physiology. But there's one of these little protozoa munching up disaccharides for the horse. And like you saw earlier, in the horse where the colon makes these sharp turns, that's a common site for impactions to occur, although they can occur anywhere along the horse's colon. We call that colic. Colic is not just one disease. It just means abdominal pain. And there's a lot of different things that can cause colic in a horse. So impaction is one. In this video, you're going to see the horse's part of the colon is actually going to twist, or what we call tors, or torsion. So again, you're looking at the back end of the horse. This is part of the colon here. There's that giant cecum, and you're just going to see, I think, this part of the there's the rectum. Anyway, you just see there's the whole colon twisting on itself. And hold on one second. Let me just give me a moment here. It's telling me my battery's low. Tell me that. Oh, shoot. Okay. Problem solved. Now, that's an overview of all of the various stations along the digestive tract. So now let's talk about, before we talk about vomiting and diarrhea, which I know you're dying to do, it's important to know, well, how does it actually work? The digestive tract actually has its own system of, its own nervous system, so to speak. It doesn't require any outside input. Just like your heart, we learned a few months ago how your heart, the brain does not tell the heart to beat. The heart has its own pacemaker cells. It does quite fine without the rest of the nervous system. The sympathetic and the parasympathetic nervous system can make the heart beat faster and stronger or slower, but it doesn't tell the heart to beat. The same is true of your gastrointestinal tract. It has its own pacemaker cells that help to initiate these waves of contraction and segmentation that we'll talk about. It's called the enteric nervous system, and you'll hear me refer to it as the brain of the gut. And so this picture is just trying to show you there's this whole plexus, this whole network of neurons that function um, without input from the brain. And that's what allows the sort of movement of food through from the stomach on down to um, your colon. There's other players, hormones like gastrin and other compounds like prostaglandins. They play a role in movement and secretions. Um, but just like with the heart, the autonomic nervous system, that's your fight or flight and rest and digest systems, they can play a role in influencing, not controlling, but they can influence um, the gastrointestinal tract. So remember the sympathetic system, that would be your fight or flight system. And the parasympathetic system, that would be your rest and digest system, right? There's a reason why it's called the rest and digest system. The parasympathetic nervous system, when it predominates, it's going to cause increased secretions of various of hydrochloric acid and various enzymes. It'll dilate blood vessels, so you get improved blood flow to the GI tract. It'll increase the smooth muscle tone and motility. Motility means movement, basically. If you've ever been really hungry, you can hear your stomach making noises and you can hear it grumbling and rumbling. That's it. That's your parasympathetic nervous system in control. This part of the nervous system uses acetylcholine as its neurotransmitter, so it's releasing lots of acetylcholine on the stomach and the small intestines. And there are some drugs that can mimic that, but we don't use those very often. There's one particular nerve. It's a very crazy nerve called the vagus nerve, and it is one of they're called cranial nerves, and they come from the brain stem of your central nervous system. And this is a really long nerve. It's one single nerve, right? So this is one single cell that travels all the way down, and it branches off at the lungs and the trachea and the heart and the liver and all parts of your intestinal system. And when you take anesthesia, you'll see the vagus nerve again. It shows up in anesthesia as well, because it can make things a little scary during anesthesia. But the reason we mention it today is because this is the nerve that is active, dumping acetylcholine on your digestive organs when you're getting ready to eat. And then your fight or flight system is going to have the opposite effect, right? When you're being chased by a bear, you don't care about digesting your food. So it's going to decrease the secretions, decrease blood flow, decrease muscle tone. And then it's using different nerves, but it's using norepinephrine as its neurotransmitter, and then epinephrine is the hormone from the adrenal gland. And I just put ENS, just stands for that enteric nervous system that you saw earlier, right? So that's what it's acting on. Now, why is any of this important? Well, you and I, we take care of animals. So let's say you have an animal staying at the hospital and you want them to eat, right? You want them to keep up their nourishment. Well, if your patient is in constant panic mode, do you think they're going to have much of an appetite? No, right? If your patient is scared and nervous and anxious, that's going to kill their appetite. On the other hand, if your patient is as relaxed as they can be, I mean, if they're in pain or sick, they're not going to be relaxed. But we can do a lot of things to help with pain, help with anxiety. You know, if it's a cat, keep them away from a bunch of barking dogs. If it's a rabbit, keep them away from other dogs and cats, right? There's various things we can do to make them feel comfortable, and then they may be more likely to eat. So now let's talk about the actual interventions we take. So one would be what are called the emetics, and emesis means to vomit, and an emetic drug is a drug that will make a patient vomit. So, so what is the function of emesis? Well, remember, we said this is a defensive mechanism. So the main function is to get rid of toxins in the body. That's the good function, right? You've eaten something you're not supposed to eat, and the body wants to get rid of it. It can be bad too, though. Sometimes the patient is vomiting due to toxins they didn't eat. They're vomiting due to toxins that are building up in their system from an infection or kidney failure or things like that. And so the vomiting's not helping. It's not really serving a purpose there. Give me 1 second here. So what can make an animal vomit? Well, like we said, there are toxins they can eat. There are toxins that can come from inside their body, but there's a lot of other things. So just maybe take a minute and think, what are some other things that have made you vomit or made someone you know vomit? Can you think of other things? There are certain drugs that might make a patient vomit. We learned about how some opioids like hydromorphone can make a patient vomit. My mother was on chemotherapy, and animals can be on chemotherapy, and that made her vomit. Sometimes if animals have an obstruction, maybe they ate a foreign object and it's stuck in their stomach or their intestines, that pain, that inflammation can make them vomit. Motion sickness, or what we might call car sick or seasick, that'll make a patient vomit. Sometimes they have motion sickness due to a problem with their vestibular system. So we'll talk about that too. And then what signs precede vomiting? This will be something useful to watch for. If you ever see this in a patient, sometimes patients won't vomit, but they're feeling nauseous. And some of these signs can help to clue you in on that. So some of the signs you may see, we'll let little Ralph the dog show us here. So you'll see patients licking their lips. You'll see them drooling. You'll see them shaking. They may vomit, they may not. But if you see patients drooling, licking their lips, looking kind of anxious, that can be a sign that they feel nauseous. And what actually happens when a patient vomits? This little video is going to show you, right, there's the esophagus, there's the stomach. You're going to see this violent reaction where food gets propelled up the esophagus. And one of the signs that you also see when patients vomiting, you'll see them kind of pumping their stomach. When they do that, they're actually moving food. I should call it chyme, but I'll just call it food. They're moving food from the duodenum into the stomach so that it can be thrown up. So that's part of that's what's happening when patients are going, is they're moving food from the duodenum into the stomach. And that show you, right? So there's normal, right? There's the normal flow of things. And now let's watch vomiting here. So, right, there's all this food and liquid and stomach acid in the stomach. Right, so there's food coming backwards, and then these various sphincters open. You don't need to know terms like ejection phase, but there goes the vomit, right? And then more food comes in, and then vomit. There it goes. So, and this is kind of gross, but just to show you, there's going to be a little video clip. It's going to show you just how violent this is. You're going to see vomit coming at you. You're going to see part of the stomach sort of prolapses, or not prolapse, but it kind of reverses into the esophagus. So you see there's part of the stomach there, right? Isn't that horrible? And to understand how emetics work and antiemetics work, it'll be helpful to kind of review exactly how neurons work. So you recall there's two different ways your body can communicate internally, the endocrine system and the nervous system. And what do we say when we say communicate? What do we mean? Well, certainly some part of your nervous system is in charge of perceiving things, right? You have sensory receptors. These are all neurons, right? I can see the room around me. I can hear myself talking. I can, smell my cup of coffee, things like that, right? Well, you also have these sensory neurons inside of you. If you've ever felt bloated, right? There's a sensory neuron inside of you that's detecting, air bubbles or stretching, right? Well, you also have these neurons in a part of the brain called the emetic center, and we'll talk about that in just a minute. For all of these neurons, right, they're communicating down these things called axons to other neurons or other organs, right? And it's very complex. And what's happening when they reach another neuron or organ, they release what are called neurotransmitters. And you've learned about some of these neurotransmitters, right? Things like acetylcholine, norepinephrine, serotonin, dopamine, GABA. There's several we've learned about. You learned about how the drugs in anesthesia will sometimes stimulate or block certain of these the receptors for these neurotransmitters. You learned how a lot of the insecticides work by maybe overstimulating or blocking the receptors to these neurotransmitters. Cardiac drugs, drugs to modify behavior, the serotonin, the selective serotonin reuptake inhibitors, right? So you've been using these knowledge of these neurotransmitters. Well, these same neurotransmitters, some of them can stimulate vomiting, and we'll talk about that. Right, and just as we were talking about, right, the neuron communicates, and when it reaches another neuron, it releases these various neurotransmitters, right? Releases these neurotransmitters that are going to bind to some sort of a receptor. And the book refers to this vomiting reflex. And so I think it's worth just reminding you or describing what a reflex is. A reflex is some sort of an action that occurs that you don't even really think about. Remember that the nervous system doesn't just take in information, it also sends out some sort of an action, right? So I can smell my coffee, well, I'm going to drink some, or I bite into this chimichanga and I can taste it. But there are certain actions that we call reflexes where they occur without you even thinking about it. If you were to accidentally touch something hot or painful or step on a nail, even before you've consciously perceived it, your spinal cord has already responded and you've pulled your hand back or you've lifted your foot up. The same sort of reflex occurs with vomiting, right? You can't really control, you can try to prevent yourself from vomiting, but if your body really needs to vomit, you're gonna vomit. All right. And so there's a part of the brain called the emetic center. And isn't that kind of weird? There's a little part of your brain that's in charge of vomit. That's what it does. It's in charge of vomiting. It's located in the brainstem, a part of the brainstem called the medulla oblongata, and it's going to be responsible for all those actions, the feelings of nausea, that pumping action, the relaxing of the sphincter. But it's all going to start at this thing called the emetic center. And how does it know? What kind of sensory input does it receive? And this is just what we talked about a minute ago. So certainly, probably the most common reason why your patients are going to vomit, in dogs at least, is they got into something they shouldn't eat, right? Some sort of roadkill or some nasty, rotten piece of garbage. We call it dietary indiscretion. Dietary indiscretion. But sometimes it's just called non-specific gastritis, or it's called garbage gut. So that would be something they ate is going to trigger the emetic center to vomit. Sometimes they eat other things, right? Maybe a lawn mushroom, something that may not be deadly. Sometimes it is deadly, but sometimes it's just enough to make them feel kind of gross, and they throw up. Sometimes toxins build up from other illnesses. So the kidneys are supposed to help you flush toxins out of your body. But patients with kidney failure, these toxins build up, and the emetic center will detect that. Livers are supposed to metabolize toxins, and then patients with liver failure, various toxins will build up. Pain, so gastritis, a foreign object, and by pain I mean like gastric ulcers, for example, or certain or parvovirus, right? That can cause a lot of inflammation, and that could cause a patient to throw up. A foreign object stuck in the stomach could trigger the emetic center. Motion sickness could do it. Even in humans, certainly you can be so scared that it'll make you throw up. I don't know how common that is in dogs and cats, but that's certainly something that happens in people. Sometimes drugs we give to help have as an adverse effect vomiting. So the opioids, that's the emetic center has receptors that can respond to opioids. So it's not a good thing. I mentioned my mother and chemotherapy. Chemotherapy can make patients throw up. And the whole point of this is sometimes we want them to throw up. And so there are certain drugs that we give them designed to stimulate the emetic center. So for example, this dog ate chocolate. Chocolate, the dog is not going to think it's a toxin. The dog is going to think it's delicious. It is not going to make the dog throw up, but it can overexcite them and cause seizures and be quite deadly. And so in this case, we need to give something to make the dog throw up. Like in the dog, we would use apomorphine. And we'll talk about that. And you'll see that dogs and cats, for example, have very different emetic centers. And so a drug that would work on a cat will not work very well on a dog, and vice versa. And just as a side note, people get morning sickness. So something about pregnancy can cause vomiting, and a hangover, can cause vomiting. Even the memory, if someone ate or drank something that made them throw up, if they smell it a year later, it makes them feel like they want to throw up. Again, this is not really an animal thing, but just trying to tie this in with your own experiences. So again, there's this thing called the vomiting center, the emetic center. It's inside the brain. It's pretty well protected by the blood-brain barrier. You remember the blood-brain barrier is what keeps a lot of drugs out. The blood-brain barrier is made up of these tight seals between blood vessels, as well as those pumps called P-glycoprotein. So anything that gets in gets pumped right back out again. That's why a lot of antibiotics cannot reach the brain. Well, there's this part of the brain called the chemoreceptor trigger zone. And you can kind of think of this as sort of being part of the emetic center. It communicates to the emetic center. You can see here's the emetic center right here. And then there's this little tiny thing that's right nearby, but it's not so well protected by the blood-brain barrier. So it's part of the brain, but it's a little bit outside the blood-brain barrier. Why is that important? Well, it means it's going to be easier to stimulate. In fact, the impression I get is that most things that make us vomit, they make us vomit because they stimulated the CRTZ. So it's good, because if there were no CRTZ, it would be really hard to make patients vomit, because very few drugs would ever reach the emetic center. But the CRTZ is fairly easy to stimulate. And I'll show you in a video. It's just constantly monitoring and sampling blood, as well as cerebrospinal fluid for any sort of chemicals or substances, right, that should stimulate vomiting. It's trying to protect you from toxins, but it can't tell the difference between, kidney failure and a bunch of poisonous food that you just ate. And this shows you, here's a dog vomiting, and we're gonna take a look here. So we said we're gonna go inside the brain, right? So here we are near the brain stem, and there's this little thing here called the emetic center. And ignore, it's gonna mention, if the video mentions like afferent nerves and higher this or that, just ignore that. Okay, here's the emetic center. And again, it certainly detects a lot of things, but right here is that that chemoreceptor trigger zone, which is a different cluster of neurons. You can see how the CRTZ, it's tried to depict it being right next to a blood vessel here. So you'll see the CRTZ, right? You don't really see it sampling things, but just imagine that it is sampling various toxins, or it's looking for various toxins, and then it can stimulate the emetic center to bloop, 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 blah. And there are a ton of different receptors. So that's what I want you to appreciate here, is that, let me just pause this real quick. So I just want you to appreciate that both on the CRTZ and the emetic center, there's not just one receptor for one chemical or neurotransmitter. There are a variety of receptors, right? There's this receptor and this funny little receptor and that receptor. The point is that the CRTZ can respond to a lot of different things. We mentioned poisons that you might eat, toxins that build up in your body, motion sickness, opioids, chemotherapy drugs, inflammation and pain, right? These are all very different stimuli, but luckily the CRTZ has lots of different receptors. And I don't care if you know what, the NK1 is, or that one, just knowing that there's a variety of receptors, right? Right, that's a lot. So it can respond to a lot of things. And then the emetic center has similar situation. I think it has not quite as many, but it also has quite a few well, I mean, it doesn't have the same variety, but it still has a lot of receptors. I think and this is just going to show you something called substance P. It's made through pain and inflammation creates this thing called substance P, and you'll just see the substance, right? And how it locks in with a receptor, and it's going to stimulate the emetic center to make you throw up. Right, so we say receptors, that's what we mean, that they're going to receive some sort of a chemical, and that's going to make the patient throw up. Although this patient changed his mind. Okay. And so these receptors, why is that useful to know? Well, one, it'll help you understand why your patient might be throwing up. It also helps you understand why why emetics work, or anti-emetics for that reason. So there's these receptors called alpha receptors, and you've learned about alpha 1, alpha 2, beta 1, beta 2. So the book just calls them alpha receptors. And when you ever hear alpha or beta, think of the fight or flight system. So excitement, pain, inflammation, these are all things that can activate the fight or flight system. And these receptors found, these might be found on the emetic center too, but this is why pain, excitement could make a cat throw up. Cats have way more alpha receptors than dogs do, and you'll see why that matters. It means we can use an alpha 2 agonist to make a cat throw up. Substance P, which is this other substance and receptor, we use an anti-emetic that's going to block that receptor. Dopamine receptors, these are the ones that get stimulated by hydromorphone and opioids, so that maybe helps you remember that. There are receptors for histamine and dopamine, and these get stimulated by motion sickness. And in fact, when we want to make dogs have way more of these receptors than cats. So this is one reason why cats don't get motion sickness the way dogs do. It's also why we can use a drug called apomorphine on dogs, which is like dopamine, but that drug won't work on cats because cats have way less of these receptors than dogs. And then finally, there's these receptors to serotonin. Chemotherapy drugs tend to stimulate those receptors. But again, we've got a nice anti-emetic you'll learn about that blocks those receptors. All right. So, so when would an emetic be indicated? So just remember, vomiting is defensive, and that if we are going to give, oh, I'm sorry, this is when is an emetic indicated? Well, again, it's like we said, when a patient's eaten something that we need to get out of them. And I think it's on the next. I'll show you. I mean, there's so many things that your patients may eat. But there are some risks. Every time we intervene with a drug, we have to keep in mind that if it's strong enough to help, it's strong enough to hurt. And there are times where an emetic would be contraindicated, and there are times where it just won't be very effective. So what are some of the risks? Well, you do not want to induce vomiting of anything that's corrosive. So Drano, bleach, these are things that they probably already did damage going down. If we make the patient throw up, it's going to cause more damage to the esophagus. And sometimes patients are sick and we don't know what they ate. And so certainly just doing an oral exam, if you see ulcers in the mouth, it might mean that they ate something like Drano, and maybe we shouldn't make them throw up. I just wanted to tell you a story about my son, Alex. When he was a little boy, I think it was one of the first times that my wife, got out of the house. And so it was just me watching him, and he and I were playing in the backyard. And by the way, this kid he you know, we had a hard time getting him to eat his vegetables. Okay, let's just say that. There were certain foods he just would not try. It was a struggle. Well, now he and I were outside, and he was out of my sight just for a few moments. And I went and I found him in the garage with this horrible, sad look on his face. And I'm like, what's the matter? And he just stared at me and he opened his mouth, and all this blue carpet shampoo came out of his mouth. And I thought, you've got to be kidding me. You won't eat carrots and peas, but you'll drink this bottle of carpet shampoo. And so I just rinsed his mouth out and he was fine. But the point is, you know, it made me think, how often do our animals eat things and we don't know. We don't know what they ate. You also would not want to induce vomiting if they've ingested something volatile, right? That means easily evaporated. Gasoline, for example. I believe it or not, some dogs will eat or drink gasoline. There are also things that are just very, just very sort of, I mean, I don't really think of mineral oil as being volatile, but it is just so light that it can be easily aspirated. And so if you look right here, right, it says if ingestion occurs, do not induce vomiting because it could be aspirated. And that's the big danger whenever we make patients vomit, is that if they aspirate some of the vomit, that could give them a really horrible pneumonia. And so, for example, I had a patient who got into marijuana, but it was a special kind of marijuana. The dog was almost in a coma. He was not in a coma, but he was obtunded. The dog was just so doped up that you just, you know, I wanted to make him vomit, but I don't know if he had a very good gag reflex. I was afraid if I made him vomit that he would just vomit and then he'd inhale some of the vomit, so I couldn't do it. I had to use fluids and activated charcoal when he got a little more awake. Mostly a lot of fluids and a lot of worrying. So that would be another time where you may not want to induce vomiting. Remember, certain species cannot vomit, right? You would never give an emetic to a horse or a rabbit. Likewise, if your patient had like a foreign object, you know, or a twisted stomach, don't give them an emetic. That they could actually, I don't know, they could rupture their stomach. And again, just to show you, the ASPCA has a very helpful website at their Poison Control Center. So these are a variety of things. Dogs will eat human medicines. They'll eat grapes and raisins and macadamia nuts and things that can be toxic. They might eat some insecticides. They might chew on some plants, rat poisons. They might gobble up a bunch of their meat flavored veterinary products. So these are all things, and most of these things, not bleach, not Drano, but a lot of these things we could make them throw up. And there are so many poisons. So if we're ever in doubt, we can call the ASPCA Poison Control Center. They charge money, right? So this is something you would bill the client, make sure they approve. But I think I think it's like a $75 call, and clinics will probably, you know, mark it up to $100 or something, because it's the veterinarian or the RVT that's going to probably be making this phone call, so it's going to be taking their time. Well, what if they ate something that would be good to make them throw up, but it was an hour ago or 2 hours ago, right? When do you know it's too late to make them throw up? Because at some point, the poison is going to be beyond the duodenum. Once it's in the ileum, then they'll never throw it up. The rule of thumb is if it's a liquid toxin, what would be a liquid toxin? I don't know. If it's going to be too late after 2 hours. Most toxins, though, are solid, rat poisons, chocolate, things like that. So even if it's 3 or 4 hours later, there may still be some in their stomach or duodenum that we can make them throw up. So how do we make them throw up? There are centrally acting drugs, right? They're going to work on the CRTZ, and there's also locally acting emetic drugs that are going to work on the stomach. And we mostly want to use the centrally acting. So one is called apomorphine. This is one that's better in dogs than cats because dogs have more dopamine receptors, and we'll talk more about that. And then there's the alpha-2 agonist, right? This is the same alpha-2 agonist that would be used as a sedative, but now we're using it for a totally different reason. We're using it to make a cat throw up, and cats have more alpha receptors than dogs. And so you could give the cat xylazine or dexmedetomidine. Well, let's talk first about apomorphine. So you recognize that word morphine, right? So this is it's a little bit confusing to me. It's an opioid, but it's also structured like dopamine. And we learned about dopamine when we learned about behavior modifying drugs. Dopamine, and I confess, I find some of this a little bit confusing, right? Because dopamine is kind of an excitatory, feel-good neurotransmitter. You know, every time you get on your cell phone and you find out people liked your Facebook post, you get a little rush of dopamine. Gambling behaviors, various addictive behaviors, we get little rushes of dopamine. Well, something about dopamine can also make you throw up. Okay. So apomorphine is not, there's no analgesic powers. And there are stories of people breaking into veterinary clinics and finding apomorphine and thinking it's morphine and eating it, and then they're sick as a dog. So so we use it in dogs, but it's kind of unusual. It can't be given orally. Of course, one problem is these patients are throwing up, so you wouldn't want to give them something. Oh no, I'm sorry, they're not throwing up. So we want to make them throw up. So apomorphine comes usually in a pill. I think maybe now it's available as an injection, but it comes as a pill. But what we do is a little unusual. We can actually put the pill in the conjunctiva. So we actually put this little pill inside the lower eyelid, and it gets dissolved. Sometimes we crush it up with water and squirt it down the nose. That's kind of weird, but effective. If it's in an injectable form, we can give it sub-Q or IM. We can't give it by mouth because of the liver, right? We learned about the first pass effect, and that's when food gets absorbed from the intestine. The first stop is the hepatic portal vein going to the liver, and the liver will just destroy most apomorphine. So we have to use another route. Because it is an opioid, it doesn't provide much pain or any pain control, but it will cause respiratory depression. You remember there are mu receptors on the brain stem, and that opioids will reduce the respiratory rate. So that's why it's nice to put the medicine in the conjunctiva, so that once the patient has thrown up, well, then you can just flush out, just take a syringe and saline and just wash away any of the medicine that remains. In fact, I think that's what they're doing here. Right? It's done its job. Now get rid of it. We don't need the patient to keep throwing up. We don't need them to get depressed. Cats, they don't have a lot of dopamine receptors on their CRTZ. So in cats, we're going to use alpha-2 agonists because cats have lots of alpha receptors. And this is a very low dose. This is lower than the dose you might use if you were to sedate a cat. And there's a little mystery. This is just a side note that we use alpha-2 agonists a lot in cats. We combine it with ketamine and butorphanol. and it's called Kitty Magic. It's a really wonderful short-acting anesthetic. That does not make a cat throw up. If you give them an alpha-2 agonist mixed up with other drugs, they don't throw up. But if you give it all by itself, it will make a cat throw up. I don't know why. And this is just kitty magic. It's just, if you hear the word kitty magic, it's referring to this combination of drugs. And so like we said, you would use an alpha-2 agonist in a cat, and you use apomorphine in a dog because they have, different numbers of receptors. The ASPCA, if an owner calls them, or if we call them and a patient's far away, you can use hydrogen peroxide to make a patient vomit. It's not that effective sometimes. It has to be fresh and so still fizzy. If you have like a too old bottle, it's not going to work. And it works because it creates all this irritation of the GI tract. And remember, we said how that's something, irritation, inflammation, can cause the release of various neurotransmitters that will trigger vomiting. So that's how this works. More in dogs than cats. So those are the emetics. Now let's talk about the antiemetics. Right. So if an emetic is going to stimulate a receptor on the CRTZ, what are these going to do? Well, they're going to block a receptor. They're going to be an antagonist to a receptor. And so why do we give an antiemetic? As we said, remember that vomiting is a natural defense. It's just that it can lead to dehydration, electrolyte imbalances, pain, right, from all this vomiting. So that's one reason why we would give it. Most of these will not be given by mouth because the patient will just throw it up. So most of these, we start out by giving them as an injection. Some of them don't come as an injection. That's kind of frustrating. But these are the ones we're going to talk about. There's the phenothiazines, and that's acepromazine. You've learned about that before. There's one called metoclopramide. Probably the most powerful is this next one. It's a serotonin antagonist one's called ondansetron or Zofran. The other one is called dolasetron or Anzimet. That's the most powerful antiemetic. Less powerful are the ones we would use for motion sickness. You know them by the names Dramamine or Dramamine 2. Meclizine is not mentioned in the book, but we'll talk about dimenhydramine. And then the other really helpful one is called meropitant, and it antagonizes that substance P. The receptor is called a neurokinin 1 receptor. So let's talk about each of these drugs here. So we've learned about acepromazine. You learned about it in the chapter on drugs that affect the nervous system and behavior modifying drugs. So this is used to, we can use it as a tranquilizer before anesthesia. We can use it for various fears, right? If a patient has a fear of thunderstorms, or a horse has a fear of getting in a trailer, we can sometimes use acepromazine. It's going to block dopamine. And dopamine, we said, is sort of an excitatory neurotransmitter. And there was a very old drug in the 50s called thorazine that was used in old people, I guess. Okay, as an antiemetic, it's going to inhibit those receptors called dopamine receptors. That's going to decrease the stimulation to vomit, right? It's more effective in dogs than cats. It could cause hypotension and sedation, right? That's really the main reason we use these drugs, is for sedation. But why is that important to know? Why is it important to know that hypotension would be a side effect? Well, think of your patients that are vomiting. Most of them may be dehydrated. Dehydration causes hypotension. So the point is we don't really use acepromazine very much. We don't use it very much when for a patient that had, say, parvo or kidney failure, right? We're not going to use it very much because it can cause hypotension. These patients already may have hypotension, and then sedation. Well, we want them to eat, and so maybe these patients aren't going to eat very well. So then when would we use acepromazine as an antiemetic? Well, not very often. Car sickness maybe would be one reason. If you wanted them to be sedate in the car as well, would be one possible use. But for really sick patients, you're not going to use this. This next bunch of drugs also helps with motion sickness. So we've learned about histamine and antihistamines from the drugs that affect the respiratory system. You have these cells called mast cells. That's what you're seeing here. They're releasing these little purple granules that, right, they release these little purple granules. That's histamine. And they play a role in the redness and swelling of inflammation, in particular when we're talking about an allergic reaction, food allergies, flea allergies, airborne allergies, as well as a vaccine reaction. Well, histamine does other things. You're going to see later it plays a role in the stomach, but it also plays a role in motion sickness. So anytime we have a problem with the inner ear or the vestibular system, somehow histamine gets released. And so some of you may not know what I say, the vestibular system. In your ear or a dog's ear, if we go down the ear canal, right, there's the eardrum, and here's the cochlea. That's what actually creates, it turns sound waves into actual sounds you're hearing. Well, right next to it is this little structure called the semicircular canals. These series of 3 canals. They have fluid and little crystals that move around, and these help you with your sense of balance. They help you know what's up, what's down. Whenever you move your head around, these little crystals and fluids are moving to help keep you oriented. Well, patients can have problems with that. Motion sickness is, creates this disconnect. You think you're not moving. Your body's telling you you're not really moving. You're just sitting there, but you look out the window and things are moving by. Something about that creates this disconnect, which we associate as motion sickness. But there are other problems. Dogs will get this problem where it's called old dog vestibular syndrome, where they're just sitting there and suddenly they act like the room is spinning, and that can make them throw up. And also, if you have an infection of the middle ear or the inner ear, that can also inflame and upset the vestibular system. So again, I mentioned, this thing called vestibular disease in old dogs, where they'll have this head tilt, they'll be rolling, their eyes are moving all crazy because their sense of balance is totally thrown off. And so what do? Well, we can use certain drugs. So this is what we might use. We could probably use acepromazine, but we could use this drug as well. We tend to use this a little more often, or what are called the antihistamine antiemetic drugs. So again, that's going to control vomiting when it's due to something involving the vestibular system, motion sickness, old dog vestibular syndrome. You could even probably use it after a vaccine reaction, although we usually give some sort of an injectable. And again, it's blocking histamine receptors. It can cause some sedation. If you ever, these are similar to antihistamines like Benadryl. And if you've ever taken Benadryl, which is called diphenhydramine, you probably know that will make you kind of sleepy. So I included diphenhydramine on here as well, because you could use that in a pinch. This next drug is very different. It blocks dopamine and serotonin receptors. That's good, but it also does something else, and it's why we call it a prokinetic. And by prokinetic, we means it's going to get things moving. It's going to actually increase movement through the stomach and small intestine. This thing called peristalsis that we'll talk more about. So it's going to increase forward movement. It'll relax the pyloric sphincter in the stomach so food can travel out. It increases muscle tone at the sphincter where the esophagus meets the stomach. So they're all going to, not only is it going to decrease the desire or the reflex to vomit, but it also kind of moves food down the GI tract. That makes it helpful for other diseases that have nothing to do with vomiting. There's a disease called megaesophagus where the dog's esophagus gets all big and floppy, and these dogs food will just sit there and they'll regurgitate. There's also a syndrome called bilious vomiting syndrome where dogs they have an empty stomach and they throw up and they get bile on the carpet. So it's not really, it's not an emergency, but these are other uses for metoclopramide. In fact, these days, metoclopramide is probably used for these more than for anti-emesis, because we've got better drugs now to prevent vomiting. But when I started in 2003, this is all we had. If I had a dog with parvo, for example, this is all I had, and it was okay, but it wasn't great. More effective in dogs than cats, remember, because dogs have way more dopamine receptors on their CRTZ. It can cause sedation in dogs, but weirdly, it'll cause cats this sort of paradoxical frenzy. I don't know why. And there are certain contraindications with it. So one is, I guess it can increase the chance of having a seizure. So you wouldn't want to use it on a patient with epilepsy. And because it's making things move, it's making the intestines move and the stomach move. You would never want to use it if there was an actual obstruction. In other words, the patient comes in vomiting, we need to make sure there's no obstruction, because if there's a rubber ball or a rock or something that's obstructing the GI tract, and we start to make the GI tract move faster, we could do real damage. And I just wanted to show you, you can see this is a dog with megaesophagus. So you see the food just kind of sitting there in the, it'll show it again, right? So instead of a nice little esophagus like that, he's got this kind of big floppy, oh, this is vomiting. Okay, he's going to show us vomiting. Okay, fine. Yep. Taking his sweet time to vomit. Great. So it's just going to show us, it'll show us regurgitating again. Oh my gosh, this is taking forever. This is the slowest animation in the world here. Okay, right? Big floppy, mega esophagus, right? And the food just kind of sits there. Anyway, so that dog would benefit from metoclopramide, right? It'll just kind of help move food along. There's another prokinetic the book mentions. It's not an antiemetic, but it is very helpful for cats with megacolon. So again, it's a prokinetic. It's called cisapride. It doesn't have any effect on vomiting, but it does help improve muscle tone in the colon. And so we use it to treat cats with megacolon, which is this particularly severe constipation that cats get, right? Just showing you that in this constipated dog or cat here. The most powerful antiemetic we have are the serotonin antagonists. Again, I don't really understand. Serotonin, I thought, was a feel-good neurotransmitter, right? A lot of the behavior drugs we use increase serotonin levels, but there's something about serotonin that can cause vomiting. And so there are receptors to serotonin. They're called 5-HT, I think. Who cares? Um, um, but this works because apparently, like mainly I've had to use this in dogs. Yeah, it's often dogs that have just intractable vomiting. So usually some sort of inflammation of the small intestines. But even patients with kidney failure, this has come in handy. So, but again, this is what we often reach for when nothing else works. And then here's the one you'll probably see most often. This has been really a blessing. It's actually kind of a cool drug. It does a lot of cool things. So it blocks this pain neurotransmitter called substance P from its own receptor. I don't know why they don't call it a substance P receptor. It's called neurokinin 1. Okay, fine. But it blocks that. And then what's kind of cool about this is it's actually working in the emetic center and not the CRTZ. So this drug can actually make it across the blood-brain barrier, and then something about that allows it to block a lot of other stimuli, and not just even though it's specific to blocking substance P, we can use it for all sorts of things. We can use it for patients that are vomiting from parvo or gastritis or motion sickness, really very different things. It's actually labeled to use for motion sickness. It's even a pretty good pain medicine. So if we have like a cat with pancreatitis, we'll sometimes give them Serenia for pain. And again, it's pronounced meropitant, or some people like me say meropitant, but I guess technically it's pronounced meropitant. As a side note, it's always kind of nice to know of natural alternatives, and ginger actually has some anti-emetic properties, some anti-nausea properties. It's not very strong, so don't, but I've had owners say, is there something natural I could give my dog? And I say, well, there is ginger, but then I tell them, of course, there's a chance your dog will throw up ginger all over the back of your car. So I warn them that they can give their dog some ginger snaps or some tummy drops, but the dog may just throw that up too. But you can see it says stomach upset, motion sickness, nausea, morning sickness. So there's something about ginger. Okay, and then just to close, this is by the makers of Serenia. It's just kind of a nice little way to close our little segments, our segment on emetics and antiemetics. So we will watch the misadventures of Ralph.
All right, Ralph, have fun.
Come on, Frankie. I can see your whole paw. Hey,
Ralph.
Hey, guys. What are we talking about? Oh, talking about the car right here. This is horrible. I was panting all the way.
And I couldn't stop licking my lips. For me, it was the drooling.
I just keep shaking alive.
I got restless in the car, and he couldn't stop whining. Oh. I paced, too. Yeah. I mean, pulled, too. Well, sounds like you've got a pretty stacked deck there. That used to be me until we went to the veterinarian. He gave me Serenia to prevent vomiting due to motion sickness. Well, you're bluffing.
Oh, it's true.
Yeah, But Serenia helps prevent vomiting due to motion sickness. So now I love the car. Boats and airplanes and bicycles.
Hey, Ralph, come on, buddy. Time to go home.
Guys, ask your veterinarian to get you Serenia, okay? See you later. Visit Serenia.com to learn more about dog motion sickness.
And some kind of good points, things I forget to mention that some of these drugs are not, pets have to be a certain age. So, you know, Serenia, they're supposed to be 2 months and older. And then 4 months and older for motion sickness. So, you know, it's kind of useful to remember that. Again, if they have a GI obstruction, you know, it has not been evaluated for these things, but we do tend to use them for those things. All right, so that's the end of part 1. And if you want to pause and go over to, there'll be a link to Kahoot, or just go to Kahoot and look for Vet3 drugs affecting the GI system part 1, and you can just do a little review. There'll be very basic questions, but I think it's more interesting than just hearing me review with you. So go ahead and stop, go over to Kahoot, do this little review, and then join me for part 2.